Good afternoon, everybody. I'm Dr. Siddhi Shanbag. I'm a junior resident from BJ Government Medical College, Pune, and I'll be presenting an interesting case report, a curious case of Pachers-like retinopathy. A 33-year-old male, known case of severe anemia, presented in emergency with complaints of burning sensation in lower and upper extremities with decreased appetite, increased fatigability since 15 days. After a panel of tests showed raised HbA1c inflammatory markers in addition to low Hb, a fundus evaluation was requested by the physician. Patient, however, had no ocular complaints. Significant past history, there was history of hemorrhoids for which he was undergoing treatment and which may justify his severe anemia. He was also a known case of chronic tobacco and alcohol use disorder. On general examination, he had generalized pallor, some stigmata of leprosy. Also, on systemic examination, there were reduced deep tendon reflexes. Also, upper limb muscle power had reduced. On ocular examination, the best corrected visual acuity for the right eye was 6/9 and for left eye was 6/6. The other anterior segment findings were within normal limits. Moving ahead, onto the fundus, the media of the right eye was normal. The optic disc was of average size and shape. The margins were clear. The CD ratio was about 0.3. However, there was a generalized arteriolar attenuation. The AV ratio was around 1:4. The foveal reflex was dull. And what is very significant are multiple cotton wool spots around the vascular arcades and a few which are peripapillary and few on the macula, all within the zone 1 of the retina. Going ahead, on the OCT, what we could see is the vitreoretinal interface was normal. However, there were areas of focal hyperreflectivities in the inner retinal layers corresponding to the cotton wool spots. However, the outer retinal layer was normal. The left eye showed similar fundus picture. There was generalized arteriolar attenuation. However, the foveal reflex is slightly better. Again, the OCT images showed areas of focal hyperreflectivities which were corresponding to the cotton wool spots. We did a fundus fluorescent angiography. This is an AV phase photo for both eyes. For the right eye, here we can see we can again appreciate the generalized attenuation of the arterioles. Also, there is the venules were tortuous and distended. What we can see are areas of blocked hyperfluorescence which correspond to the cotton wool spots. Also, there are multiple microaneurysms. The similar picture was seen in the left eye. So we came with the provisional diagnosis of Pachers or Pachers-like retinopathy. This was an incidental finding. The patient was already worked up since he had a long stay with the physician. Significant or noteworthy investigations were his HB was 7.2, HbA1c was raised, which was 7.2 again. The SGPT and OT levels were raised, which may be contributed to his alcohol use disorder. Then the CD4 is to CD8 ratio was reduced, but however the ratio was more than 1. CSF analysis showed raised proteins and other parameters. Inflammatory markers were raised, however he did not tick for any autoimmune profile. On pathology, all the biopsies which were duodenal, sural nerve or skin biopsies showed normal to moderate infiltrate of lymphocyte, but no soft tissue disorder or vasculitis could be ascertained for sure. On radiology, there was bilateral upper limb and lower limb motor neuropathy. So, given that the classic picture of Pachers-like retinopathy, a few leading questions were hence asked, but the patient did not tick for any of these. The management was basically from the physician's side. The rheumatologist opined that the patient might have DMA myotrophy, which was again provisional, and he was given a course of IV immunoglobulins 10 gram per day for 5 days. No ophthalmological management was indicated. On follow-up visit, this is after 6 weeks, we can see that the number of cotton wool spots are the same and the size has reduced. Discussion. Now, Pachers-like retinopathy is a traumatic retinal angiopathy which is characterized by complement-mediated leukoembolization. However, when features of Pachers retinopathy present without a history of frank trauma, we call it as Pachers-like retinopathy. The most commonly seen case of Pachers-like retinopathy is acute pancreatitis. However, our patient did not fall for any of these already known causes of Pachers-like retinopathy. Also, for our patient, what is very important is we kept a close follow-up because sometimes the optic disc pallor and RNFL atrophy can set in. Hence, this is my interesting case, and what is very interesting is that we should look for association between diabetes and punctures like retinopathy. Thank you. These are my references.
So you could not identify a cause
Yes, sir.
for this,
Yes, sir.
but your patient was anemic
Yes, sir.
and he had history of hemorrhoids.
Yes.
So could straining or Valsalva cause the same?
Yes, sir, it can. But so what is significant is, given that he was anemic, he should have some hemorrhages as well. Like we see in ocular ischemic syndrome, we don't just have the cotton wool spots, we also have an amalgamation of hemorrhages. Yeah, or we could also suspect if there were some rot spots, then that would have gone in the direction of anemia. You're right, for Valsalva, he might have, that might cause cotton wool spot, but he was pretty comfortable right now with his management. So even the surgery, people didn't think that his hemorrhoids were necessary enough for a surgery.
And what was the course further after the examination? How did they resolve?
So after we have basically done nothing ophthalmological side, from the ophthalmological side. After IVIG or probably whatever the positive agent for the cotton wool spots has worked, and hence the cotton wool spots are reducing. The number are being reducing.
The cotton wool spots would have reduced by themselves also.
Yes, yes, sir.
So you don't need a therapy for that. But you couldn't find a cause. Why was IVIG given?
For diabetic hemorrhage, for the proximal muscle weakness. That was rheumatologist's opinion.
All right.
Yes, ma'am. Yes, ma'am. Agreed, ma'am. Ma'am, that's why this patient definitely doesn't fall into the Putsch's retinopathy since he has no trauma. But there's a spectrum called as Putsch's like retinopathy, which will have the similar findings. Okay, ma'am. Okay.
Thanks, Siddhi. So we
Thank you.
have next Anju is presenting. Anju is presenting on retromode. Does it provide a newer insight into dry AMD? Yeah, please.
My topic is, does retromode, does it provide newer insight into dry AMD? As we all know, AMD is the leading cause of irreversible blindness among populations aged 50 years or more in India after diabetic retinopathy and the glaucoma. Incidence of dry AMD is 85 to 90%, rest is contributed by the wet AMD. The number of people affected in 2020 were 196 million, which is likely to be doubled by 2040. Main sites of pathogenesis is reduced membrane, RPE, and the choroidal structures. The most accepted classification, AREDS classification, was based on 30-degree color fundus photo. But drusen's which are less than 25 microns can't be detected clinically, so various modalities like OCT, OCTA, FF, and retrocam. So retro mode imaging is specifically designed to see the alteration at the level of the RPE. It incorporates the infrared laser, which have the two apertures, right deviated and left deviated. So structures with scattering incident light laterally are seen using this mode. Advantages of retro mode are, it is a very sensitive modality for detecting drusen and smaller drusen which are easily detected compared to the color fundus photo. It enhances the subtle features of low-lying drusen, and it gives acute characterization of the retinochoroidal deposits, and it can even detect smallest alterations. Aim of our study was to study the role of retromode in early detection and to compare it with other pre-existing modalities on multimodal imaging system in dry AMD. It was a prospective observation cross-sectional study done on 409 eyes of the 207 patients. Patients included were of age 50 years or more with no early and the intermediate AMD. Mentioned below are the exclusion criteria. Eyes were divided into three groups according to the size and the number of drusen, namely Group 1 no AMD, Group 2 early AMD and Group 3 intermediate AMD, which were further subclassified into two subgroups. This is the color fundus photo, FF and retro mode photo of the no AMD, early AMD and the intermediate AMD. Coming to the results, this is the demographic profile of the patient. This table shows the number of drusens detected by the color fundus photo, FAF and retro mode in the various stages of AMD. We also compared between the two modalities, color fundus photo and retro mode, color fundus photo and FAF and the retro mode. This picture shows how we calculated the number of drusen using the software. Apart from calculating the number of drusen, we also calculated the extent in the form of area of the disease involved using color fundus photo, FAF, retro mode. So to conclude, retro mode is found to be better diagnostic modality in detecting more number of drusen with area of involvement than any other existing modalities. Though superior as found in our study, this mode can't replace other modalities at present, but only act as a complementary investigation in early detection of this disease. Hypothesis: lesser the severity of disease and smaller the size of drusen, there is more chances of false positive count. FF shows more number of drusens compared to the color fundus photo and retro mode in smaller size drusen and in early stages of disease. As the depositions become more defined, that is in the intermediate stage, pickup rate is more on the retro mode. Limitations of our study was it was a cross-sectional one-time study. Further longitudinal studies are needed to provide superiority of this modality over present modalities. Thank you.
Dr. J, you want to take this? Dr. Mudra Anand Puranik, please be ready in the next
Yeah,
podium.
Anju. So it's a good, I think, a good study.
Thank you,
How
sir.
many graders did you have for the grading? How many graders did you have?
Sir, 2.
Two graders. So what is the kappa agreement between them?
Less than 0.05.
The kappa agreement.
Yes, sir.
Okay. So because, did you also look at the OCT pictures also for these?
Sir, we checked the OCT and we measured the chorioretinal thickness.
Okay.
And as the stages advanced, the chorioretinal thickness decreased.
Because this is a good imaging modality that is, I think, recently evolved over the last 6 to 12 months. But we do get a lot of artifacts in this also, the acquisition and all also. So that is another limitation that can be there in the study, yes. But nonetheless, it is very promising also.
So just a question, when you said that you are counting the drusens and this is the counting method, what was the counting method?
So we marked the drusens manually and then we put the image in the software, image software, and then it calculated the drusens.
Okay, so as Jay said, this technique is not so accurate. Any elevation on the RP would be picked up on a retro mode. How do you differentiate whether it's a drusen or not a drusen on the retro mode?
But sir, we are manually marking the drusens so we can eliminate that artifact.
Okay, thank you.
Okay, sir.
Did this change your diagnosis in any of the cases or change your management in any of the cases?
So we can manage the patients whether it is converting from dry AMD to wet AMD, and we can plan the follow-up.
How do you do that? How do you get wet AMD in retro mode?
So there will be black shadow on the retro mode, their window defect.
A retro mode and you have a color picture. How is a retro mode better than a colored photograph?
So smallest size drusens are not picked up on the color fundus photo. That can be easily picked up by the retro mode.
But it won't differentiate, a retro mode will not differentiate wet to a dry AMD. Or sorry, a dry to a wet
So
AMD.
when we are talking about the only retro mode, we can differentiate whether it is converting from dry to the wet AMD. But when we are comparing from color fundus photo to retro mode is, as we have studied in my
How
study.
do you say if a dry AMD is converted to a wet mode by retro mode?
So when it is
What is the
converting
sign
into
on
the
a
wet
retro mode?
AMD, the halo-like structure which are picked up on the retro. So my study is on dry AMD only.
Can you just point out one drusen on the retro mode?
Yes, sir.
Just give the projection to that.
Just one picture of what you counted. Which one
So
is
see,
a
this is
drusen?
the drusen. If it is converting into the wet
No,
AMD,
which is
they-
the drusen here on the retro mode?
The white,
so this
the
is
white
the wet.
ones,
These
the
are the
dry
drusen.
AMD. This is the drusen on the color fundus photo, and this is on the FAF. This is whitish-like structure, and on retro mode, this is if it is converting into the wet AMD surrounding halo-like structure of black color will be there because of the fluid.
Okay, right. That's what I wanted you to point out, because this is done only in Mirante, and we have been trying to do that, so that's why I wanted to ask you. Thanks.
So does the macular pigment also affect the counting of the drusen? Does it affect, because if you see there's a very dark area in the center part in the foveal area. So does the pigmentation also affect the quality of the
Yeah,
image?
sometimes you see, sometimes you're not able to, it also depends upon the way the rays are striking the retina. So if you have an uneven surface, you don't get a retro mode picture. Thank you.
Thank you, sir.
We have Dr. Mudra Anand. She'll be presenting a case of excellent prognosis after immediate management in central retinal artery occlusion.
Good afternoon. I'll be presenting a case of Good afternoon. I'll be presenting a case of excellent prognosis after immediate management in central retinal artery occlusion. My co-authors are Dr. Ayush Sangole and Dr. Ranjana Pandey. We declare no conflicts of interest and no financial disclosures. I present the case of a 53-year-old male with sudden painless diminution of vision since 30 minutes. The patient had no other ophthalmic complaints or no similar complaints in the past. He had no history of any systemic illnesses like diabetes or hypertension. In the general physical examination, he had a markedly raised blood pressure of 180 by 110. Rest of the general physical examination was within normal limits, and his systemic examination was also within normal limits. The ophthalmic examination of the right eye showed a visual acuity of 6 by 6. The iris pupil was normal in size and reactive to light. The anterior segment was within normal limits. And the left eye showed a visual acuity of hand movements close to face and a relative afferent pupillary defect. The fundus of the right eye was within normal limits. The significant findings in the left eye were a cherry red spot at the macula, box scarring of flow in the blood vessels, and retinal whitening with a ground glass appearance. The OCT of the right eye was normal. The left eye showed hyperreflectivity of inner retinal layers due to edema and hyporeflectivity of the outer retinal layers. The patient was given ocular massage. First, we used topical anesthetic proparacaine 0.5%. Then we used a 4-mirror Sussman gonio lens. The massage was given at a total of 60 minutes at regular intervals for 20 seconds, followed by sudden release for 10 seconds. At 15 minutes, we took an OCT and we observed that the hyperreflectivity is decreasing. Because there was improvement, we continued with the massage. We also gave tablet Dimoxstat. At the end of 1 hour, the patient's visual acuity had improved to 2 meters. He had significant corneal edema. The OCT showed reduced hyperreflectivity of the inner retinal layers. The patient was also medically managed with injection labetalol 20 mg in 10 cc NS over 2 minutes by the physician. The BP at 15 minutes was still raised, and hence the same was repeated. They also gave him tablet amlodipine 5 mg stat. He subsequently took discharge against medical advice. The investigations he underwent were the following. The complete blood count, ESR, CRP, and RBS were within normal limits. However, he showed a grossly deranged lipid profile. The patient presented again to us after 17 days. He had been started on amlo and enalapril for hypertension by his physician and atorvastatin 40 mg HS for hyperlipidemia. The ophthalmic examination, the visual acuity was 6 by 9. The fundus showed tortuous vessels, rest of it was normal. The OCT showed reduced hyperreflectivity of the inner retinal layers. This is subsequent photos of the OCT. This is the at first presentation when the patient was HMCF, then after 1 hour when he was counting finger 2 meter, and then after 17 days when he presented with 6/9 visual acuity. This is the fundus photo Unfortunately, because we don't have a fundus camera in our OPD and it was an emergency, we just took it on our mobile. That's the left-sided picture, and the right is the fundus photo at 17 days when he was 6'9". So central retinal artery occlusion, basically you have a thrombus or an embolus that reduces perfusion to the retina. They have very poor prognosis and their presenting vision is in counting fingers to nil, no PL. It's an ophthalmic and systemic emergency which needs prompt management and urgent referral to a stroke center. You get a golden period of around 90 to 120 minutes to perform interventions such as ocular massage, paracentesis, giving acetazolamide, mannitol, or inhalation of carbogen. Despite all of this, it still has a poor prognosis. The theory behind ocular massage is that a steep increase in pressure and a sudden return to normal pressure will plunge the embolus distal into the vascular pathway with less catastrophic compromise to the retinal blood supply. So a prompt diagnosis and early treatment is crucial to dislodge or lyse the embolus and prevent irreversible retinal damage and blindness. These are my references. Thank you.
Dr. Rahul, you want to take this?
So while giving the pressure with the mirror, have you seen the occlusion of the central retinal artery pulsations on the slit lamp, or it was given?
It was given on the slit lamp, sir.
And how long it was given?
It was
For
given
1 hour.
using the Sussman lens. We gave it for 20 seconds, then quick release.
Good documentation. Yeah.
Thank you, sir.
Dr. Kastub, if you could be ready, please. So what happened to the RAPD of the patient?
The RAPD was still present, sir. At the end of 17 days, it was still present.
At 6'9" also there was RAPD present.
There was RAPD. I think the most important factor was that he presented early, ma'am. The patient's fortune or misfortune was such that he was in our college campus. So he had the worst probable condition on ophthalmology in the best probable place. So that was the most important thing. Immediate management, I think, and because it was an embolus, which we were, I'm sorry, ma'am. The patient was 53. 53.
Thanks. No. It's good to add, but I think what we will just ask one question and because otherwise we'll be short of time. Yeah, thanks. Thank you very much. We call the next presenter, who is Kaustubh Revatkar, presenting on changes in ocular milieu after vitreoretinal surgeries. Are you there?
Yes.
Yeah. Please.
Good afternoon, everyone. I am Dr. Kaustubh Revatkar. I am a resident from Sarakshi Nethralaya, Nagpur. I will be presenting you my paper with changes in the ocular milieu after vitreoretinal surgeries. So basically the aim of this study was to assess the changes in the ocular milieu after vitreoretinal surgery with various type of endotamponades. These ocular parameters were endothelial cell density, central corneal thickness, and the intraocular pressure, preoperatively and the postoperatively at 1 week, 1 month, and 3 months. So study was conducted at Sarakshi Nethralaya, Nagpur for the period of 16 months on the 130 patients, and it was approved by the ethics committee. Inclusion criteria for this study was a patient undergoing pars plana vitrectomy for a retinal detachment, macular hole, epiretinal membrane, vitreomacular traction, proliferative diabetic retinopathy, and the other retinopathies, excluding the patients with the pre-existing corneal dystrophy, degeneration, history of glaucoma, trauma, or uveitis, non-retinal dystrophies or degeneration. With also we excluded the previous history of any intraocular surgeries other than the cataract surgery, and the patients with less than 15 years of age. So we divided our patients into 3 groups: group 1, 2, 3, and 4. Group 1 having phakic patients with the silicone oil, group 2 pseudophakic patients with the silicone oil, group 3 phakic patients with gas or air as an endotamponade, and group 4 pseudophakic patients with gas or air. So results. Considering the endothelial cell density, the changes from preoperative to postoperative condition are shown in this table, which are well represented in this line diagram. As if you can see, with all the groups, the endothelial cell density is gradually reducing over the period of time, uh, comparing with the preoperative condition and the postoperative condition. In all the groups at all the stages, the changes were statistically significant. Now, central corneal thickness. The central corneal thickness changes wasn't that significant as as if you can see in this line diagram, the pseudophakic with oil, the changes, the central corneal thickness was gradually increasing in both the groups, pseudophakic with oil and the pseudophakic with gas, and a phakic with oil patient, the central corneal thickness was gradually reducing over the period of time. Considering the IOP we measured after adjusting with the central corneal thickness, and we did it with the Goldman applanation tonometer. The IOP showed initial rise in the early preoperative period, which then we intervened with the anti-glaucoma medications, which later on controlled the IOP of the respective groups. The change in the IOP was clinically significant, statistically significant in the early preoperative period of 1 week and 1 month in phakic with oil group and the pseudophakic with oil group. With this, my conclusion is, with various endotamponades, pars plana vitrectomy leads to the significant change in the ocular milieu in terms of the anterior segment parameters like endothelial cell density and the intraocular pressure. The decrease in the endothelial cell density was comparatively less in the phakic groups as compared with the pseudophakic groups. This implies that the natural lens has the protective effect over the corneal endothelium. IOP rise was noted more in the cases where silicone oil was used as an endotamponade, whereas very less cases had IOP rise in a gas or the air group. IOP rise was controlled by the use of anti-glaucoma medication, and none of them required surgical intervention. Central corneal thickness changes in early postoperative period at 1 week might be due to the corneal edema in some patients, which gradually reverted to normal in 1 month with routine postoperative medicines. Changes in CCT was insignificant at 1 and 3 months in all groups. Thank you.
Very interesting series. So if I ask you one question, what is the single take-home message that you have from your study? What would it be?
We have to preoperatively assess the endothelial cell density of the patients undergoing vitreoretinal surgery.
Okay. And what would be the mechanism? Why do you think the endothelial cell count is going down?
Anterior chamber compromise might lead to this effect.
Okay. So any changes you do, like all these patients were they 23 gauge, 25 gauge, was the IOP maintained throughout? So what was the IOP that was maintained during the surgery?
Sir, IOP maintenance was depending upon the surgery step which we were doing.
Okay.
All the surgeries were done using the 23 gauge vitrectomy.
Okay. So there are a lot of intraoperative parameters that can also affect all these things, including, like, suppose if you are doing a simple retinal detachment, there may be lesser IOP fluctuations. If a patient is undergoing a diabetic vitrectomy, you may get bleed, you may raise the IOP that is there. So many of these factors are also can have an effect on all these things. So were those parameters considered? So did you subcategorize also based on the indication?
No, sir.
Maybe that is one thing that you can do, so that may give us a better idea.
Yes,
And if any of these patients had any intraocular complications, were those patients more liable to developing all this reduced endothelial cell count? Is what you can look at.
Yes, sir.
One of your exclusion criteria said retinal degeneration. Did you exclude lattice degeneration?
No, sir. Not peripheral retinal degeneration, only
So what do you mean by retinal degeneration?
actually I mean regarding the central macula, which
What was the duration of surgery considered? Duration of surgery considered?
duration of surgery roughly around 1 hour.
No, but it was not considered as one of the criteria for assessing The longer the duration of surgery, the more the problems that can happen.
Yes, sir.
That
But
was not considered.
no, sir.
Thank you.
You have another presentation. Those eyes speak a lot,
Yes.
right? You can go ahead with that. And Dr. Mudra Anand, you please be ready on the next podium for your next presentation. You have one more, right? Okay, so this is duplicated with us. Dr. Ruchi Agarwal, please be ready on the next podium.
Yes, sir. So my other topic is those eyes speak a lot. This is a very interesting case study. We did this study to evaluate the cause of the choroidal folds in two patients with no other obvious ocular findings. Methodology. We conducted this study at Sarakshi Netralaya, Nagpur. It's a case report study done on the two patients complaining of the headache and the insomnia were routinely examined for the ophthalmic evaluation. Fundus examination revealed choroidal folds with no other significant ocular findings, and multimodal imaging was done, including the fundus photo, fundus autofluorescence, OCT, retro imaging, OCTA, and V-scan, along with the systemic investigations. So, starting with the case 1, there was a 54-year-old female presented for headache and insomnia. Her BCA was 6.6 in both eyes. Anterior segment was within normal limit. Fundus examination revealed choroidal folds at macula in the both eyes. Both eyes, fundus photo, OCT, retro, FAF, OCTA, and V-scan was done. Both eyes CT and MRI done to rule out retroorbital lesion, if any, except for the axial length, which was in the range of hypermetropia. No other positive finding was suggestive of the secondary choroidal folds were noted. On color fundus photo, there was an undulation of the RP involving the macula. OCT revealed combined undulation of the retina RP and the choroid. FAF revealed alternate hyper autofluorescent and the hypo autofluorescent bands. Retromold revealed taut bands in all over the posterior pole. OCTA revealed prominence of the lines at the choroid, chorocapillaries, outer retinal choroid complex, and all the level there was no evidence of any underlying pathology. B-scan revealed increased CRT. Now case 2, there was a 43-year-old female presented with headache and the blurring of vision. On examination, her BCVA was again 6.6 in both eyes, anterior segment was within normal limit. Fundus examination revealed choroidal folds in macula in both the eyes. Again, same process was followed. There was no positive finding was suggestive to the secondary choroidal folds, and patient was advised blood investigation, which revealed deranged T3, T4, and TSH values. Again, color fundus photo revealed undulations of RP involving the macula. OCT again combined undulations of the retina RP and choroid. FAF here revealed alternate hyper-autofluorescent and the hyper-autofluorescent bands, retromode, taut bands in all over the posterior pole. So choroidal folds are the striae which predominantly involves the posterior pole of fundus. These are usually arranged parallelly in the horizontal fashion and reflects the undulation of choroid, retinal pigment epithelium, and the neurosensory retina. These lines vary in the length and width and rarely extends beyond the equator. These lines can be idiopathic when no known cause is found, or secondary to a variety of conditions ranging from benign conditions like acquired hyperopia to inflammatory conditions, tumors, or post to surgery. My conclusion is routine fundus examination and thereby multimodal imaging helps in the diagnosis and assessing the systemic disease like diabetic retinopathy or hypertensive retinopathy. In our study, it helped for the earlier diagnosis of the thyroid eye disease. Thank you. These are my references.
So did you do orbital imaging in any of these patients?
Sir, CT and MRI we did.
On seeing choroidal folds, I think that would be one of the things that you would want to do in a patient if you're not finding any intraocular cause for that.
You are implicating thyroid for the choroidal folds?
Yes, sir.
Mechanism?
Sir, there is a antibody autoimmune complex reaction of the thyroid receptors in the retroorbital tissue, so which might lead to the choroidal fold.
Okay.
What is the refractive error? Did you do the axial length measurement in these patients?
In the first patient, there was a significant hypermetropia and axial length was reduced.
I think, thank you. We'll go to the next presenter. Maybe the next person, who is this? Ruchi, next is Ditisha Datta. Can be ready on the other side. Dr. Ditisha Datta is there?
Dr. Ruchi, please go ahead.
Good afternoon, everybody. I'm Dr. Ruchi Agarwal, Junior Resident at King George's Medical University, Lucknow, and I'm presenting my paper on randomized control trial for comparing conventional versus wide-angle non-contact viewing system for scleral buckling surgery. I do not have any financial disclosure or conflict of interest. The management of retinal detachment, the goal is to seal the tear to prevent further fluid from entering the subretinal space and to relieve the vitreous traction. Basic principle for any surgery, whether it be pars plana vitrectomy, scleral buckle, or pneumatic retinopexy, is identification of the retinal breaks, induction of aseptic chorioretinal inflammation to create a seal, and the chorioretinal apposition via external or internal tamponade. The scleral buckling surgery aims to indent the sclera and choroid by providing an external tamponade that brings the retinal break closer to the retinal pigment epithelium and displaces the subretinal fluid away from the tear, thus facilitating the reattachment of the detached retina. The commonly used illumination and viewing system has been the indirect ophthalmoscope with a plus 20 diopter or a plus 30 diopter condensing lens. Here we are comparing it with this new endo-illumination system via a chandelier inserted through pars plana in combination with the wide-angle intraoperative viewing system. The aim of my study is to evaluate the results of treatment of rhegmatogenous retinal detachment surgery using a non-contact wide-angle viewing system and comparing it with the traditional scleral buckling surgery using an indirect ophthalmoscope. There have been multiple studies done, but the limitations are that these studies have been retrospective with a smaller sample size. There has been a lack of comparison group, and they have not been done in Indian population. So the study design is a randomized single-blind control trial at a tertiary care center in northern India. The patients diagnosed with rhegmatogenous retinal detachment with PVR less than grade C were included, and the intervention given was scleral buckling surgery using wide-angle non-contact viewing system with chandelier illuminator. The comparison group were the patients undergoing surgery with an indirect ophthalmoscope. The outcomes measured were primary outcome was anatomical reattachment of retina. Secondary outcomes were improvement in BCVA and per and post-operative complications at day 1, 7, 30 and day 90. The selection criteria were patients presenting with rhegmatogenous retinal detachment, eligible for scleral buckling surgery and ready to be followed up for 3 months. Patients with deep set eyes and post-glaucoma patients were excluded. This was a randomized control trial and CTRI registration was done. A concert 2010 flow diagram was followed and 46 patients were included, divided into 2 groups. Group A with the newer technique consisting of 23 patients, and Group B with the conventional scleral buckling with 23 patients. The descriptive stats was analyzed and the statistical analysis was done using MedCalc software, and the categorical data was represented in frequency and proportion and continuous variables by count, mean, standard deviation, median and minimum maximum. The descriptive stats were comparable between 2 groups. The operating time was evaluated and the arithmetic mean in Group A was 122 minutes while in Group B was 111 minutes, and this was significantly higher in Group A. The primary outcome, that was reattachment of retina, was evaluated by chi-square test and the difference was not statistically significant between 2 groups. Similarly, the change in BCVA was not significant between the 2 groups. These are the per-op complications. Subretinal bleed was present in 2 patients in both the groups, and in Group A, additional complications due to shifting of the chandelier, lens touch causing cataract and vitreous incarceration at the post site were seen. Post-op complications between the 2 groups were similar. There were media haze due to subretinal bleed and unattached retina in 1 patient in both the groups. So previous studies have been done. In 1980s, Bonnet M used a operating microscope with slit lamp illumination with a Goldman 3 mirror lens to visualize. And in 2004, OG, M and Tano Y used a surgical microscope with a slit lamp illumination and wide field contact lens to perform scleral buckling surgery. Optic fiber-free intravitreal surgical system was used by Naraki et al. And Aras et al. Did a similar surgery to performed a similar study to ours, but a torpedo-based light source was used in their study. In our study, these are the advantages and disadvantages that we experienced. The insertion of chandelier illuminator was via a trocar and cannula and a small port size. It was easy to adjust, change, and the site had need not be closed with a suture. A wide field of view was seen and adjustable magnification was provided by the slit lamp. Comparable rates of attachment and post-op BCVA was seen as with indirect ophthalmoscope. It acts as a good teaching tool because the surgery can be demonstrated, unlike that with indirect ophthalmoscope, and better ergonomics were seen. Disadvantages were intraocular entry, poor view in hazy media, increased operating time due to lack of experience and need to change the position. The limitations of my study was small sample size and learning curve. The chandelier illuminating assisted scleral buckling surgery thus yielded comparable results and can be used for the rhegmatogenous retinal detachment, and it yielded good results compared with the traditional scleral buckling surgery. Thank you.
Nice study, Dr. Ruchi. So you said you had increased operating time with chandelier. Why do you think you had that?
So in our study, this was all the surgeries were performed by a single surgeon, and they were performing it for the first time. That is why the operating time was more because of the lack of experience. Also, certain complications like the lens touch causing cataract in one patient, also vitreous incarceration at one side. These complications had occurred because of the lack of experience, and this was a limitation of my study.
And about this hazy view, I think in a hazy view, we prefer chandelier buckling rather than indirect ophthalmoscopy. If I have a hazy cornea or a corneal opacity, I personally would prefer chandelier rather than an indirect. So how do you draw that conclusion?
So in our patients, we saw that for us, it was maybe because of the coaxial viewing system, we experienced more difficulty in a dense cataract. In cases of dense cataract, we experienced more difficulty in performing via a chandelier.
So when you did your chandelier observation, indirect ophthalmoscope was completely not used.
Yes, sir. In that surgery, the complete visualization was done via chandelier. Even the drainage was done under the direct view via chandelier, the subfluid drainage. In that case, indirect was not used at all.
Okay. Thank you. We go on to the three papers that have come from the previous three sessions. We call upon Jasmeet Chandi. She's here. You're presenting a multimode imaging in bullous CSCR with spontaneous retinal pigment epithelial rip. So the best paper from this particular session would be marked. We will not call you again, and we'll mark it with the three papers itself.
Good afternoon, everyone. Myself, Dr. Jasmeet. I'll be presenting a case of bullous central serous chorioretinopathy with spontaneous retinal pigment epithelial rip. A 34-year-old male presented to our department with the chief complaints of sudden painless loss of vision in the left eye since 1 month. There was no history of trauma or any steroid intake. There was no significant past family history, and he was not suffering from any systemic illness. On ocular examination, the visual acuity was 6/6 in the right eye, and it was 6/36 in the left eye with no improvement on correction. The slit lamp examination of the anterior segment of both the eyes was unremarkable. The IOP was normal, and the gonioscopic examination was normal. This is a fundus photograph of the right eye showing CDR ratio of around 0.3. The vessels are normal. There are multiple RP changes at the posterior pole. This is a fundus photograph of the left eye showing CDR ratio of around 0.4. Vessels are normal. There is an inferior bullous retinal detachment, an area of RP atrophy, and neurosensory detachment at the fovea. We did an autofluorescence. In this, the right eye shows hyperfluorescent areas. In the left eye, we can see a hypofluorescent area, which is corresponding to an area of RP tear, surrounded by an hyperfluorescent area due to retracted RP. This is an OCT image of the right eye showing multiple neurosensory detachments with shallow PED. This is an OCT image of the left eye showing shallow subretinal fluid at the macula, PED temporal to the fovea with RP rip at the fovea and the rolled out edges of the RPE. This is an FFA image of the right eye showing multiple pinpoint areas of hyperfluorescence in the early phase, which increase in intensity in the late phase. This is an FFA image of the left eye. We can see well circumcised area of hyperfluorescence in the early phase, corresponding with the loss of RPE, which increases in intensity in the late phase, with a narrow portion of blocked fluorescence on the inferior margins consistent with the retracted RPE. So I come to differential diagnosis that the patient could be suffering from Vogt-Koyanagi-Harada, which is ruled out here because there was no history of any uveitis or extraocular manifestations. He could be suffering from sympathetic ophthalmitis, but there was no history of trauma. The other causes could be posterior scleritis, choroidal tumor and metastasis, and uveal effusion syndrome. So my provisional diagnosis is bilateral central serous chorioretinopathy with left eye inferior bullous RD with RPE rip. Focal laser was done to discrete leakage areas in both the eyes. Spontaneous retinal pigment epithelial rip has been reported more commonly in neovascular ARMD, post-trauma with intravitreal anti-VEGF injections and CSCR. RP rip usually occurs at the junction of detached and flat pigment epithelium. Tears was first reported by Hostin et al. Reports of RP defects in association with CSCR are rare. Steroid usage is an exacerbating factor. Our patient developed a spontaneous RP rip with CSCR without any history of steroid intake. Another interesting fact is that the RP rip was seen at the dome of the RP detachment and not at the edge of the PED as seen in age-related macular degeneration. So I conclude here by saying that bullous retinal detachment is a rare manifestation of chronic central serous chorioretinopathy. RP tear may rarely occur in CSCR, particularly when the neurosensory detachment is associated with underlying PED. Due to its peculiar clinical finding, it can represent as a diagnostic dilemma and lead to inappropriate management. Treatment is still a controversy. Failure to differentiate bullous CSCR from other diseases may result in inappropriate usage of corticosteroids, worsening the clinical picture and leading to a poor visual outcome. Further studies are mandatory to address this issue and improving patients' care. These are my references. Thank you.
Dr. J, just one question from you. Dr. Malika ma'am, if you can be ready on the other podium, please.
Yeah, excellent case, Dr. Jasmeet. So, how did the patient respond to the treatment with the focal laser?
So there was not much improvement after the focal laser, honestly, and we asked the patient for a follow-up, but we lost the follow-up of the patient, but we did counsel him about if there is a deterioration in the visual acuity. So we counsel him about the other treatment modalities in the form of external drainage surgery or oral treatment in the form of epinephrine.
Okay. Were the serum cortisol levels done for the patient?
No, sir.
Was okay. Because that is another thing, that you can consider for
Right,
these
sir.
patients.
Yes,
Even
sir.
though patient may not be taking oral corticosteroids, but
Right,
the
sir.
internal, those cortisol levels may be high, especially in these patients who have these larger ribs with bullous RD. So that's a
Okay,
very
sir.
important investigation, that you can consider in your
Okay.
case.
Thank you, sir.
Presentation by Dr. Malika. She'll be talking about retinal sequelae of COVID-19 infection. And is Sumit around? Sumit, you're there? Okay. So you should get your presentation on here next.
Thank you, Dr. Arora.
Switch the display to the other podium, please.
I'm sorry, I'm the odd one out here. All these are students, and so I'm. छोड़ो, अभी सीखने का टाइम नहीं है आपका. छोड़ो, हटो यहाँ से.
Sumit, लगा दो.
कम से कम आने तो दो वहाँ. Poor audiovisual, Dr. Arora.
So they are not able to get this.
No, they are not able to. Since morning, he didn't make any attempts also. This 3 hours back, same problem. Just go and sit down there. Okay. So I'll be presenting retinal sequelae of COVID-19 infection. The case series can be classified as infections that were secondary to immunosuppression caused by COVID infection and its treatment, and post-viral sequelae such as AMN and PAM, and post-fever retinitis. Treatment-related adverse effects including CSR caused by steroids and retinal vascular occlusions. So this was a 46-year-old male who called while he still had active COVID infection with vision loss, and when he visited us, he had endogenous endophthalmitis, most likely fungal looking at the appearance, but microbiology negative, resolved with treatment. The interesting thing was that he had become a diabetic during the COVID infection only, which was a common theme as we see in the next few cases. Then we had an elderly gentleman, non-diabetic, but developed cerebral and ocular infection during COVID disease, and was aspergillus on smears and resolved on treatment. Then we had a patient, elderly patient, who developed candidemia during COVID infection and had candida retinitis on routine screening and treated successfully. We had a middle-aged lady who called during her active COVID infection that her vision was blurred. When she recovered from COVID, this is what we saw. Again, she had become a de novo diabetic during the COVID infection, probably from steroid use, but COVID also causes insulin resistance and can induce diabetes. So we investigated, everything was negative. She also had splenic abscesses on the PET scan, and both these lesions resolved with a trial of anti-tubercular therapy. Another young man whose AIDS got uncovered during the immunosuppression caused by COVID and presented to us later with a tuberculoma. An elderly gentleman recovering from COVID had poor vision, was treated with steroids elsewhere, not responded, so referred. So we started him on antibiotic levofloxacin because of its excellent bioavailability. Toxo IgG was positive, that was the only thing positive, so added Bactrim. He resolved, but we don't know the cause for the choroidal abscess. Young man with paracentral scotoma, sudden onset following COVID infection, and we found a subtle whitish deep retinal lesion on the fundus photograph corresponding to OCT disruption, RP disruption on OCT. And we also had some other lesions on the OCT in the superficial retinal layers of both eyes. So the deeper lesion was AMN and the superficial were bilateral PAM. These are reported as post-fever lesions, post-viral lesions. Then we had an elderly gentleman who had retinitis, vitritis, who had not responded to antibiotics given elsewhere. So when we saw him, we started steroids and he resolved, confirming the diagnosis of post-fever retinitis. Another younger gentleman with post-COVID retinitis did not respond to steroids and had to give him ranibizumab bilaterally with complete recovery. Then we had some patients who were on voriconazole because they had systemic aspergillosis and other candida infections because of COVID. COVID predisposes to systemic and other fungal infections. So they had multiple visual symptoms, but objective ocular evaluation and perimetry were normal. So we reached a diagnosis of voriconazole-related visual symptoms, which are harmless and reverse easily on stopping the treatment. We had several patients with mucormycosis secondary to COVID, and again most of these had become diabetic during the COVID infection. And then we had some of these patients with retinal artery occlusion. We had one young gentleman who post-COVID developed central retinal vein occlusion, no other comorbidities. So possibly this was COVID-associated coagulopathy. The physician treated with steroid and anticoagulants, but he needed an anti-VEGF for resolution of his macular edema. Thank you.
Wonderful, Dr. Malika. Beautiful collection of cases. I can only say
Thank you.
this.
Thanks.
Very good. We can have the last by Sumit, pigment epithelial detachment scarring index in neovascular age-related macular.
Good afternoon to all. My topic for discussion today is longitudinal changes in pigment epithelial detachment scarring index, a new imaging biomarker in wet AMD. I don't have any financial disclosures. So these are the spectrum of patients which we see in AMD. The top one, if we see, there is presence of drusenoid PED, and the ultimate stage is the presence of fibrotic tissue. This is somewhere in between where we get the presence of fibrovascular PED. where we can see the presence of serous fluid as well as some hyperreflectivity suggestive of the neovascular tissue. So all these three can be differentiated by seeing the OCT just based on the reflectivity pattern. So based on this premise, we try to evaluate a novel automated biomarker, PET-C, in the quantification of anti-VEGF related effects and assessment of the disease activity in neovascular AMD eyes. This was a retrospective analysis, and we included treatment-naive neovascular AMD patients who received anti-VEGF treatment, and we included only patients with PED on OCT at baseline. BCVA and OCT images were taken at baseline 3, 6, 12, 18 and 24 months. CMT and SRF area were calculated directly from the OCT images, and we used our proprietary automated image processing technique to classify the PED into three components, that is serous, neovascular and fibrous component. Subsequently, longitudinal analysis of PET-C and other OCT biomarkers were performed. So this is in brief how the PET-C scoring was done. So on the left hand side we have an original image which shows the presence of a fibrovascular PED. Upon processing and subsequent PED segmentation, what we got was three color coded areas. So the serous was coded as red, the neovascular tissue as blue, and the fibrous tissue was coded as green. So PET-C was calculated by the fibrous area upon the total PED area. The results, we totally analyzed 43 eyes from 37 patients, and these patients through the course of 24 months received 13 injections. Overall BCVA showed minimal worsening, that is increase in the logMAR by 0.07, and through these 24 months the mean PET-C score also showed a reduction of 0.04, which was statistically significant. PET-C score showed a weak negative correlation with the BCVA logMAR, that is with the worsening of visual acuity, PET-C score also showed a reduction. These were the other parameters which were analyzed, like CMT, subfoveal choroidal thickness, SRF area and IRF area. The PED area to be noted here showed an increase in the size over the full follow-up of 24 months. So from 0.38 millimeter square at baseline, the PED area at final visit was 0.47. This graph shows the increase in the PED area as seen by the purple line here, and the green line we can see that initially there was a slight increase in the PET-C score, and subsequently over the follow-up it kept on reducing. So these are some of the representative images. In the top left, if we see, there is presence of fibrovascular PED, however the hyporeflectivity within the PED shows that it's mostly serous. So that's how the PET-C score showed that it should be around 0. Subsequently, upon treatment at 12 months, the BCVA also showed an improvement to 20/25, and the PET-C score also was noted at around 0.823. These green areas all suggest probable areas of fibrosis. These again are three patients who were followed up at 24 months. The patient A, if we see, there was deterioration in the vision during the follow-up visits. PET-C score right from the baseline, that is 0.45, it kept on reducing, as can be seen by the slight reduction in the green areas. The patient B, we see that there was improvement in the visual acuity, and the PET-C score also showed a mild increase in the score, like it was 0.087 at the final visit. The patient C, the initial baseline visit was 20/60, and at the follow-up visit at 24 months it was 20/30. So we see that there was increase in the PET-C score. At the final visit there are multiple green areas which suggest that the PET-C score had increased. There are multiple limitations with the study. First of all, the quality and variability of images are an issue. Even if we see this graph here, the pixel intensities, the serous, neovascular and the fibrous area, they have a bit of overlap among them. There are also issues with small PED because the algorithm was finding it difficult to quantify the areas which have very small PED sizes. Again, PED is a ratio. As in our case also, we see that the scarring, actually the name is counterintuitive, so it should increase with the loss of vision. However, in our case we saw that it was just the opposite. So therefore we planned some another name also for this. So to conclude, the longitudinal analysis of PET-C supports its utility as a biomarker, and its correlation with PET-C with the visual acuity is comparable to the other imaging biomarkers. Thank you.
Thank you. So that brings us to the end of the session. I'll give the sheets to Dr. Semban. He'll put them together and submit it to the office. and I think they'll convey the results of the 4 sessions of VR3 papers. I don't think we will be announcing it here. We'll allow the office to announce and communicate to the author who is winning the prize.